do chapter 66. So altered level of consciousness is not a new concept for you. Some of this will be a little bit of a review, but I think it's very important. Again, I've been stressing how this is never a normal turn of events for a patient. This can be one of the key signs and symptoms to understand that there is a neurologic deficit, problem, concern, change in a patient's status. So we are going to go over this again. Okay. So make sure that you go over just the basic definition. Okay. So signs and symptoms, what would you see? Can they respond? Can they not? Were they completely alert? Were they making eye contact with you and they are no longer doing so? Motor response. Can they obey commands? That's why it's key. Every time you go and do a first initial assessment, no, maybe you don't need to check pupils every single time, but at least grips, pushes, pulls. You don't know this patient from anybody else, and you won't know their baseline or their status if you don't check. Okay? Respiratory status. Again, the brain controls every little movement we do, every little thought, we take so much for advantage. We can stand up and get going as quickly as possible, get startled and run without another second thought. Our body has gotten us up, gotten the proper blood flow, the proper perfusion to allow this to happen, to be able to raise my hand automatically with just that thought. We do everything so quickly. That's that autonomic regulation. Our brain sends those messages automatically throughout our body to tell it what it needs to do. If that is not working anymore for some reason, like an automobile accident, severance of the spine, things like that, we can lose function. So this goes back to no sensation in our arms and legs, inability to get sexually aroused, inability to void, inability to have a bowel movement. As this goes up, if the injury goes up, inability to breathe on their own. So they won't know or understand, to breathe. Eye signs, movement, able to make eye contact, track, pupil dilation. I said reflexes. Please look at that table in 66.1. Please pay attention. Be very aware of your neuro assessment. Okay, so decorticate and decerebit. This is posturing that shows this is a neurological issue going on with your patient. A little way of remembering it is, so both of these patients have a neurologic deficit right now. They're having neuro injury. So decorticate is towards the body. Decerebit is what? Away from the body. Okay, they're now pointed away. The way I like to remember it is away from the body is worse. They are going away from the body. Okay, so here are some of your main areas of concern, areas for interventions, ineffective airway clearance, depending on the severity of this neuro issue, risk of injury, deficit volume. If our neuro integrity is not intact, we're not going to be able to eat. We may not be able to eat. We may not be able to chew, swallow. Nutrition is going to be huge. Oral mucosa, skin integrity, movement, thermal regulation. If our autonomic regulation is not working, what does our body tell us? If we're hot, we sweat. If we're cold, we shiver. That response is not going to come anymore either. Okay? Bowel movement, as I stated earlier, sensory perception. This is why somebody who is paralyzed and they can't feel maybe from the waist down, they don't sense that they're sitting on something. They don't sense maybe if their leg is touching a cold surface, like a very hot cement type of seat, things like that. So they don't have the response, right? The reflex to move, that it's painful or it's uncomfortable. This can cause a crisis that we'll get into further in the lecture. They can't, do the jerk that something's burning or cold. So they've lacked that. The message center, remember, has been cut off wherever this injury is, and they can't do that anymore. Now, an interruption of family process. If this is going to be a lifelong injury, a lifelong process, think of the family dynamics. Okay, when a brain injury happens, we know nothing. What do family want to know? Everything. Is this forever? Are they ever going to recover? We don't know that, and we never will. Time is the only thing that's going to say and tell. It could be years, it could be weeks, it just depends on the severity. You know, it needs time to heal. The brain is not a forgiving organ. The skull, if you think of the skull, it does not stretch, it does not expand. There is no room for anything more than the CSF it floats around in, and the brain and the cord. There is no room for anything else. So if there's a bleed, if there's an injury and that brain is swelling, serious damage can come from the brain because there is nowhere for the brain to go. The skull. Think of it. Think of that, okay? So let's talk about family interruption a little bit more. I got off track. Sorry. Think of a single parent or a married couple. You know, the strain it'll cause on them. Newlyweds. They were going to start a family. You know, you're one income down. Instead of now being romantic partners, you are now a caregiver. Those lines become very blurred. You start looking at caregiver fatigue, family fatigue. The patient is angry, is scared, doesn't want the help, can lash out, you know, due to the insecurities of not mourning the stature of what they had in their home, in their relationship with their children, with their spouse. It's a huge, huge life-altering change for anybody that is involved. Okay, so some of the problems you want to think of is, again, distress and failure. If you see that this is a concern with this neuro deficit, what is the main goal? You want to maintain your airway. You want to make sure you have optimal perfusion, optimal I can't talk this morning. Oxygen levels. My goodness gracious. Okay, we may have to lay them down and intubate. We may have to increase oxygen. We may have to do a face mask depending on the severity. But we do need to maintain that airway and keep the optimal perfusion. This decrease in movement, decrease in perfusion, lung expansion can lead to, of course, pneumonia, aspiration from this weak swallow reflex, not able to use those muscles properly. Remember, not have understanding or use of these muscles. So aspiration risk is very high. Pressure ulcers, why? They are not moving. They are completely reliant and dependent on you. You know, range of motion, turning, padding up those bony prominences. Preventions of these DVTs, that would be some SEDs, right? Movement, contractures. Contractures can be very painful. This is a permanent deficit to a body. Somebody who is in a critical care setting, right? They are at the mercy of our care. They are at the mercy. They literally just lay there. If we do not, as we talked about a little bit in respiratory, right? That range of motion, what families can do, every bony prominence, every limb, every reflex, move it. Have family help. That little bit of range of motion, you know, just the fingers up and down. These little things can prevent foot drop, right? This is a permanent thing that if the foot does this, they won't be able to walk again. It'll stay this way. It's also a very painful thing for the patient. So we want them to have, if there is a chance of recovery, muscle strength, we don't want them to lose these muscles and have them contract permanently. Okay, here's some goals. You want to maintain that airway, as I stated. Movement, protection of injury to whatever optimal level this patient can do. Attainment of fluid balance. Somebody who has had this issue with altered level of consciousness, maybe this has been prolonged, maybe this is to a new injury. We control everything. We have to maintain that they are hydrated, maintain electrolyte balance, again, skin integrity, corneal irritation, thermal regulation, environmental stimuli. Things can start upsetting them. Calm down. Anything that in anywhere, if it's too chaotic in any environment, somebody who is confused, not aware of their surroundings, even though they can't talk, even if they can't understand, they're fearful. They still have an understanding that this is not correct. This is not how things were. Something's changed and they have no control. A calm environment with a familiar voice, less beeping, not talking around the patient. As I went over in an ICU setting, talk to the patient. Do not talk around them about your weekend plans. Okay? Maintenance of intact family and support. You are taking care of the whole family and not just this patient. If we are having an altered mental status, that is going to be a permanent issue. There's going to be a lot of collaborative care that comes into this as well. And absence of complications. We have to take care of the patient as a whole. You know, when, as a new nurse, when you walk into a room to do an assessment, even now, you have to think to yourself, you look at this patient like, I don't even know where to begin, right? It's not natural, or it's not second nature yet. You know, you start from the top of the patient and you go down. You're assessing from the minute you walk into a patient's room. You know, are they looking at you? Are they able to smile at you? Are they doing normal gestures? Are they having this conversation with you? Can they answer your questions? The conversation you start with them, if they can, that's still a portion of your assessment. You know, how they're engaging with you. And as you do, you start from the top, right? The top meaning what? Eyes. Are they tracking? Can they look at you? You know, skin integrity, arms, right? Movement. Just get your way all the way down so you don't feel you've missed anything. And this is how you'll be able to understand the patient's needs. All right, intervention. One of the main goals to compensate for the patient's loss of protection reflexes is to assume responsibility of total for the patient, as stated. Protection also includes maintaining the patient's dignity and the patient's privacy. This is huge. We're not going to go out there saying, oh, he's losing it. Okay? We have to respect them. It goes back to those simple things you've learned first semester we talked about, right? Decluttering a room, keeping them safe, possibly a bed alarm if they are very, you know, or if this is severe, protecting their body as a whole, patting the bed, okay? Turning them. Maintaining that airway is huge. Again, if you see there is any kind of respiratory issue, that goes right up to the priority center. And if there is, okay, frequent monitoring of this, they can change at any moment, including auscultation of lungs. I have said this 1,000 times, especially to my clinical group. One initial assessment is not enough, especially if this patient's critical. Their status can change at any second. So listening to these lung sounds every time you go in the room is imperative. Or maybe you hear something different when the patient's breathing. You know, you can hear sometimes the status change as it's just the patient's trying to breathe out loud. Positioning to promote accumulation of secretions. So that 30-degree angle, right? Not all the way up, not all the way down, kind of that almost a little below semi, to make sure that what? That suck swallow, if they need that suctioning help. This helps if they have any kind of issues, that it prevents from aspiration as well. Okay, suctioning is huge here because we don't know how that suck swallow reflex is at the time. Oral hygiene, why? Especially if they're intubated, right? It's a very infectious area, very full of bacteria. This is one area where they can suffer a complication, acquire some kind of bacterial infection, sepsis, okay? So tissue integrity. So areas of high potential breakdown, as I was saying earlier, just like bony prominences, elbows, ankle bones, wrists, some people who are very thin, their spine. So careful positioning, making sure people are not, you know, scrunched up in the bed, or half on their back, half here. You know, make sure the patient is aligned. Range of motion is huge here. Use of splints, foam boots, trochanter, all these things will support and help and promote the body to keep its movement level in hopes that this patient will heal. Specialty beds will help move the patient, give air to position the patient, and give pressure where needed. Clean eyes with cotton balls and moist saline. This is the area just, you know, to keep moisture out, any kind of crust around the eyes. Artificial tears for dry eyes. Even the movement of blinking could be lost in something like this. And oral care, I can't stress this enough. Okay, so fluid status. Again, we have full control. We have to take care of this body optimally in hopes that they can heal, you know, to the best of their ability. So those strict eyes and nose, making sure that they are properly hydrated. You would check this the way you would check anybody else, with skin turgor, mucosa. You know, keep giving IV fluids. Also at this point, making sure electrolytes are stable. We're not sure if they can possibly eat normally or not, depending on how severe their altered mental status is. Again, chewing, His aspiration, we're not sure if they can do any of these movements right now. So possibly an NG tube, G tube is going to be needed here. Maintaining body temperature, what does that mean? Making sure we don't cover them up completely and overheat them. Making sure we don't have too many layers of clothing. Making sure, and this comes down to decency and common respect. When we leave a patient's room, make sure they're covered. And not just covered, not too much, not too little. Make sure it makes sense for the patient. Check the room temperature. I can't tell you how many times I've walked into a room and this patient is not covered up. The gown is still up here and they're showing their goods everywhere. So it's common sense. How would you want to be dressed at this point? If the room is cold, cover them. They cannot maintain this themselves. Keeping socks on them. Having the common courtesy to know you don't want to wear the dirty socks that you've been walking around in. Put the clean socks on. Okay? All right, if temperature is elevated, minimum amount of bedding. Okay, just what I said. Administer acetaminophen. Use hyperthermia blanket. There's cooling blankets. There's warming blankets. The facilities still have them, but they're not around as easily as this slide says. It takes an order. They don't warm enough. They don't cool enough because of risk of even more injury. So we try not to do that. And just know it's going to take time to get one. Monitor temperature frequently, use measures. Again, your assessment's going to be constant. It's not going to be just every 4 hours, every 2 hours, depending on the severity of the patient. Okay, so bowel and bladder function. Somebody like this, and they can have some minimal movement. You want to probably do some training up every few hours. Assess. You don't want to forget the incontinence. Possibly the use of, and it's going to depend on patient order. We have to maintain skin integrity. Catheter may be okay for temporary. Bladder training. This may be they're on a schedule like everything else. If they can get up to or sit up for a bedpan, if they can use a bedside commode, you have to set an alarm for yourself and know this is how they are going to get retrained, and the same for the bowel. Okay. How would you know? Distension, discomfort. Bowel movements are just huge in a hospital setting. We're constantly wondering, please make sure you chart a bowel movement. Please make sure if you don't chart a bowel movement. I am on my students constantly in the clinical setting to make sure. I can't read your mind and I don't know. Neither can the nurse. And if you don't chart it, you're going to forget a few years later if there's something happens to this patient and it's called up that you have to re-go through this chart. If they didn't have a bowel movement, put a 0. If they had no urine, put a 0. That shows you looked, you didn't neglect them. And what else does that mean? They didn't have any for 8 hours. This is going to start to show everybody who's caring for this patient. Heads up, they're dehydrated. Heads up, they're constipated. We need to do something about this. If it's just a blank chart, that doesn't mean anything. You're leaving things up to interpretation. You do not want to leave patient care up to interpretation. All right. Diarrhea may result in infectious medications. Diarrhea can be very common here because of maybe change of medications, change of environment. Okay. Change of flora. C. diff is rampant. So a bowel regimen is going to be huge here, like stool softeners. All right. Sensory stimulation and communication. Talk to the patient, as I stated. Have a conversation with this patient every time you're in this room. You are talking to this patient. You're introducing yourself. You're telling him what you're doing. You're having the conversation you're going to have with your coworker, but with your patient. I'm going to move your arm now. I'm going to place the pillow back here to make sure you're comfortable. You're never going to indulge if there's confusion. If they are talking, you're just going to reorient them back in a nice way. You are going to encourage and talk to the family to treat this patient and do the same. Patients are very fearful when it's been such a traumatic experience to even touch their loved one, especially if it's in an ICU room and an ICU bed with numerous cords and numerous tubes, and this injury is tragic or this injury was devastating. Let them know it's okay to touch them. Let them know it's okay. That's the best medicine. Studies have shown, and if you really pay attention and watch, you'll watch a patient's blood pressure decrease, their respirations come down, their heart rate come down, and their body just be less tense when they hear the voice of their loved one. It's sad and fulfilling at the same time. When arousing a patient from a coma, a patient may experience a period of agitation, minimize stimulation at this time. If a patient has been out of it and it hasn't been in any kind of sense of reality, of course they're going to be agitated. Of course we're going to want to protect them. This is going to go back to that constant assessment. This is going to go back to communicating with each other of how the patient is doing. Programs for sensory stimulation. This is just like any other kind of occupational therapy. You know, touch, sense, feel. A patient with any kind of injury neurologically has to relearn everything over again, even the fundamentals. Okay? Provide support. This is a collaborative effort. Families should be involved every step of the way. Okay, so now we're going to talk about increased cranial pressure. So we've been talking about altered mental status and some causes. Any kind of brain injury can cause this increased cranial pressure. As I said, the skull doesn't stretch. It's not forgiving. The brain is not forgiving. When we get a cut, when we injure ourselves, the first response is what? That immune response. Our finger will swell, the ankle will swell, whatever was injured will swell. It's detrimental to us. It's life altering. It's possibly permanent damage if this happens to the brain. And we possibly can never be the same. I know I'm going to be asked this. This needs to be an obvious statement. You need to know the levels. If it's in here, if it's on a table I provided to you, you need to know the ICP levels. You need to know a normal range. When you guys stop and ask these questions, I want you to ask yourself this. Do I need to know these levels to take care of my patient? Do I need to know it's too high and this could damage my patient? My levels are too low. I need to let somebody know. It is not about your test. It is about your patient. This is how I teach, and this is what I want to get across to you. Okay? I don't remember all levels at all times. Okay, but if I have to take care of a patient in this while I am refreshing myself, I am reminding myself. So yes, at the current state you're in as a nursing student, you need to know your levels. Okay? So let's start from the top here. Again, that pressure, that limited space causes this increased cranial pressure, this imbalance. So look at the normal levels here, 10 to 20. Okay, this happens from injury and from disease. Okay, so it decreases perfusion, blood flow. Okay, this causes cell death, permanent disabilities and damage to the body throughout. Brain tissue may shift through the dura and result in herniation. Autoregulation is what I've been talking about this whole time, will be affected. Okay, the ability to change diameter, blood vessels to maintain a cerebral blood flow. So we're going to see a change. Remember, if we don't have autoregulation, we can't control perfusion, we can't control the blood pressure, so that blood pressure is just going to drop. If this patient is in a crisis for some reason, they're not positioned properly, they're laying on a pencil that we left in the bed, a needle cap, the body cannot respond. It's going to respond by spiking a humongous blood pressure. It's an emergency response. We are going to get into that right now. CO2 plays a role. Decreased CO2 results in what? Vasoconstriction. Increased CO2 results in what? Vasodilation. The body doesn't know the difference. It can't get the signals through because we don't have autoregulation. And here we are. We have to control everything. All right. So brain with intracranial shift. So look right here. There's no room. So it's starting to protrude in different areas. This causes pressure. This can cause bleeding. This can cause cell death. All right. So CCP stands for cerebral perfusion, closely linked with ICP. Both of these you need to know. This is how you find a mean arterial pressure right here. This is the formula. A normal CCP is 70 to 100. Less than 50 results in permanent neurologic damage. You need to understand all these levels. You need to understand how to interpret them. Okay, so manifestations. 66-2 again has all of them. Our nursing role, every sign and symptom, everything. I give you kind of the basis here and the main points. Change the level of conscious. That's the early sign. Please know that. It is never okay to not be lucid. Okay? So again, that early subtle sign of maybe they couldn't answer what day it is. And they're kind of just rambling on and not making any sense, you know. We can say they're just tired, they didn't sleep well. You know, it just gets brushed off unintentionally. So please understand, these early things can be life-altering to this patient. Okay, any change of condition. Restlessness. See, these are vague. I'm just tired. I didn't sleep well. Confusion. Increased drowsiness. It's not just because they didn't sleep all night. Increased respiratory effort. Purposeless movement. Pupillary changes. We could have, at some point, our pupils can change in diameter. They could have two different ones. This is not a good sign. Weakness in one extremity over the other. Why? Because it depends on where this poor brain is being compressed. Constant headaches, increased intensity, and how normal is a headache? How normal? I just have a headache. Okay? So let's talk about this. How could we acquire this? This could be something, any subtle change, maybe a patient with a motor vehicle accident, right? Fell and hit their head, had a swimming pool accident, banged their head at the bottom of the pool. These are things I've seen. I had a small child one time, not a small child, like school age, I think it was like 10. She was putting something in the trunk and the trunk fell on her head. It was a very old car and the trunk just crushed her head and she was stuck with her head in the trunk of the car. So she had to be sent into the ER just to be monitored to make sure there was no changes, swelling of any kind. They didn't do any kind of scans or tests. They watched the child's behaviors to see if this was going to be any kind of issue. Okay? Constant increase of intensity, aggravated, so it's just not going away. It's probably one of the worst headaches of their life. All right. So late signs, respiratory and vasomotor changes. They're not able to control this anymore. Vital signs. Here we go. Mark this, highlight this. This is huge. Widening pulse, pressure, Cushing's triad. What's going on here? We have an increase in systolic. Widening pulse pressure, slowing of heart rate. Pulse may fluctuate rapidly from tachycardia to bradycardia, so very rapid changes. And temperature increases because of lack of control. Cushing's triad, here we are. Bradycardia, hypertension, bradykapnia. They start to separate. You need to know this. You need to be able to interpret it. This is one of the biggest signs and symptoms that there is a problem and we need to act fast. Okay, projectile vomiting. It is just what it sounds like. It's not just a little spit up. It goes flying like the exorcist. Further deterioration, again, change of level of conscious. Lack of level of conscious, stupor or coma. Right around here is probably where you're going to start to see maybe that change in positioning, possibly. Decorticate, decerebrate, hemiplegia, decortication, decerebrication, flaccidity. Respiratory pattern alterations includes Cheyenne strokes, breathing, loss of brainstem reflexes. So again, the pupil changes, different pupil changes, lack of reflex and swallowing. All right. Process. What is our role in this? History. So what does that mean? Where were they when this happened? What happened? How long have they been this way? Has this been going on a long time? Was this just a current accident ahead? I had a dear friend of mine that somebody came from behind him and hit him with a metal bat. So again, where were you? What happened? He wasn't able to speak or talk. So it was family. It was friends that had to explain how he got this injury. Evaluate mental status. Again, it's constantly time, date, name, date of birth, cranial nerve. So again, how can we do that? Can the patient obey commands? So let's smile, right? Let's track. Grips, pushes, pulls. Can they obey command? These are big ones here. Cerebral function, reflexes, Glasgow Coma Scale. Yes, you need to know this. You need to be able to interpret a Glasgow. If I give you a number, you need to be able to interpret it. High means what? Low means what? There is a Glasgow Coma Scale in your book. Pupil changes. Again, frequent vitals. I already said and showed you right now how important these vital sign changes are. So please, 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 we're probably going to be checking every 15 minutes, maybe every 10. But these subtle changes, it is considered an emergency. Okay, assessment of intracranial pressure. We need to be monitoring that. So how do we monitor? Just like this. We usually have to put a line into the brain and watch these levels. Okay. A few interventions is removing a piece of the skull to allow the brain to swell and to put a line in to check. But consider this. Okay, we're watching, we're monitoring, we're checking, we've done this. Okay, but to do what I'm asking, you now have to have an opening into the brain. What is this patient at risk for? Infection. So again, we are going to cause an extreme risk of infection, sepsis, something horrible to monitor. I'm going back to, again, every decision you make is life-threatening to this patient. These patients are critical, so you have to understand everything is life-threatening. So you are choosing now to put this patient at risk for infection to monitor ICP. You have to. This is life-threatening as well. There's cause and effect for every decision that is made for a critical patient. This is just a sign of intracranial waves. All right, so here's your ICP monitor. It has a transducer here, okay? It has a level here. ICP is huge. A patient has to be at complete rest to help with increased cranial pressure. Any upsetness, any excited stimuli can cause that increased cranial pressure. So part of the interventions for this is to keep a room quiet, dim the lights, decrease the sounds, the bells, the IV monitoring, decrease the 20 visitors possibly, and the taco spread that's in there, and the music and the laughing, and some cultures have so many people in the room. You have to decrease the stimuli. If this patient gets excited in any way, shape, or form, again, they are not lucid. How are you checking this patient? I need you to imagine an ICU setting. You still can tell by vitals, posturing, movement, grimacing. Okay, this is how you tell. If that patient's blood pressure is going sky high, this is where some of the ICP will go right here, the fluid right here. And you'll see a patient that starts to get upset or excited. They'll start pouring fluid in here. And the pressure will increase. That's how the fluid goes in here. Okay? I wish you guys could see it, really. Here's the catheter system. This is what it looks like. Okay, diagnosis. So up on top is the airway clearance. Can they breathe? The pattern, the cerebral perfusion. So it's constant monitoring of these things at this time. Fluid volume deficit, IV fluids, fluid and electrolytes. Risk for infection is huge here. All right, collaborative problem complications. We could have a herniation. So we have diabetes insipidus and SIADH. These are two huge complications that unfortunately are very common and happen with people with a brain injury and ICP. I added these slides in for you to reference both. Okay? There's other reasons why a patient could acquire SIADH and DI. I only put on here how they would acquire this with a neurologic injury. So please, this is what you need to know. Understand it. Okay, so SIADH, which stands for what? This is a hormonal issue. So syndrome of inappropriate antidiuretics. So what's going on here? We can't control anything. This poor patient's body, right? So here we are. So patients with SIADH cannot excrete, dilute urine, retain fluids, and develop a sodium deficit. I've been saying this whole time. You have to maintain an electrolyte balance, okay, known as dilutional hyponatremia. So what does this mean? Think about lack of sodium. What would you see in a patient? Same concept you've learned since semester 2. Disorders of central nervous system, such as head injury and brain surgery, so they're not able to distribute it properly. All right, so management, eliminating the underlying cause, which is what? The brain injury, the ICP, whatever the case may be neurologically that is causing this lack of imbalance. So it's not as easy as fixing the neural problem. So we have to monitor it and identify that we have this complication, and we have to what? Treat it, but it's not going to go away until this neuro injury or the patient starts to heal. So understand that. So what do? We have to identify why they have it, the cause we have. It's a neuro injury in this one. Okay? If possible, restricting fluid intake. This patient more than likely is just on IV fluids. Diuretics, but what's else? We're going to have more of an imbalance. So we need to get some of that fluid off, though. The fluid that's in the improper places, and that's third spacing. Okay? Severe fluid restriction with hyponatremia is present. All right, closing, monitoring fluid intake and output, daily weights. If these patients are not lucid, intubated, we have beds that can do these daily weights. Same concept, right? Same, if they had socks on, if they have a gown on, remove the blanket, same positioning, same time of day. Okay? Urine and blood chemistry, so you're constantly checking the urine. The urine's going to tell you a lot. Neurologic status indicates a patient is at risk. So we know we have an injury. We know possibly this is coming on this poor patient. All right? All right, so here's the other complication, diabetes insipidus. No, this isn't type 1 diabetes. No, this isn't type 2 diabetes. This is a diabetes on its own. It has the same signs and symptoms. It's going to affect the patient in those same aspects. This isn't something a patient keeps, like type 2. Okay? So, excessive thirst, large volumes of dilute urine. Okay? It may occur secondary to head trauma, brain tumor or surgical ablation, eradication of a pituitary gland. So here is a head trauma and a brain tumor. This is probably what we would probably see for this neuro issue. Okay? With infection of a central nervous system, like meningitis, encephalitis. So any kind of neuro injury, you are at risk for acquiring this. The management. The objective of the therapy is to replace the hormone. So here is the reason. We are lacking these hormones. They have too much of these hormones because our brain is not regulating what we need or don't need. Okay? So to ensure adequate fluid replacement, identify correct and to replace the ADH. Pharmacological therapy, we use some desmopressin, okay, to help with this. Assess, identify. So what would be a sign and symptom of this? Maybe you're coming into your patient's room, they haven't had a lot of output, they're barely meeting minimum requirements, right? 30 mLs an hour, whatever the case. You go in your room for your hourly check in this ICU environment, because that's how many times you have to be checking and being in this room. And all of a sudden you see that catheter bag full of clear, very light yellow urine that is maybe 800-900. Does that make sense? Because the last time you were in there was maybe only 60. This is one of the biggest signs. So it's a kind of a subtle sign as well if you're not paying attention. Okay. So some of the care, some of the biggest priorities here, that airway, that respiration, fluid balance, infection here, adequate cerebral tissue infusion, okay, respirations, and absence of complications. So what would be the complication? Contracture, skin integrity, DVTs, perfusion issues. We are controlling blood pressure. We are controlling heart rate. All right, interventions. Constantly monitoring respirations, head of bed to prevent any kind of aspiration, airway, 0 to 60 degrees to prevent venous drainage. So we don't only possibly have an ET tube in, we have the intracranial monitoring in. So right here it's telling you they should not be any lower. So as I stated earlier, you want a decreased environment. You want to be able to cluster your care. If you see your patient's not tolerant, that blood pressure is going sky high and that ICP is going sky high, you stop your care. Regardless if it's, oh my God, I have to give this medication. You cannot let that ICP go that high. If it's a bathing, usually in ICU environments, they bathe the patients at night. The patient's not tolerating it, you stop. If the patient needs clean sheets under, you stop. Okay? It goes back to what the patient can tolerate, and it may not be much at first. All right? Avoid hip flexation, Valsalva maneuver. So you don't want a patient with ICP to cough, to fart, to bear down, to push. Why? It'll increase ICP. Maintain a calm, quiet atmosphere. As I stated, perfect fluid status. Every hour I know. Strict aseptic technique to manage ICP. You are under strict, you know, some of the biggest risk for infection is in an ICU environment. Why? Because of the many tubes, the many cords are in this patient, the many openings, the long environment, they're immunocompromised. You know, a lot of the reason people get infections in a central line, infections from this ICP, is because of us. We skipped a corner. We didn't rub our IV ports with alcohol long enough. We quickly just brushed on it. We didn't do it at all. I see nurses that don't do it at all sometimes. We didn't wash our hands before we walked in. We didn't wash our hands when we left. We didn't change gloves after cleaning their bottom. Please understand, your life is in their life is in your hands. And something as simple as washing your hands properly, changing your gloves frequently, not skipping corners, and really chloroprepping what's necessary, alcohol wipe what's necessary, dressing changes appropriately, not skipping any step because you are busy. Okay? Risk for infection is huge, and it's solely because we skip corners as nurses. Okay, so surgery, craniotomy. So it's kind of, I told you earlier, we move a portion of the skull to allow the brain to swell. It removes tumors. It relieves elevated ICP. That's what I'm talking about right now. A blood clot possibly from the injury, and controls hemorrhage. This is one of the biggest ways to control a brain injury and hopefully to allow it to heal and run its course. Burr holes is another way of allowing an injury to heal and to release. This could be a fall to the head that caused a small bleed and will allow for that to be removed, a hematoma. Here's a picture of burr holes. So if a patient has this type of surgery, they go straight to the ICU. A CT MRI is some of the biggest studies prior to diagnose to understand that it's necessary to have this. Medications are usually given to reduce risk for seizures. Corticosteroids, fluid restriction, hyperosmotic agents like mannitol, I would know mannitol, and diuretics may be used to reduce cerebral edema. Antibiotics may be given to reduce potential infection. More than likely, they're going to be on a round of antibiotics after a procedure like this. Diazepam to reduce and alleviate anxiety. Can you imagine how fearful and how scared? Okay, there's still a lot that's not known with brain injuries, but the fear you see in a patient's eyes after going through something like this, they have no idea what is going on, possibly who they are, and they're aware that they don't. Okay, so, oops. Really quickly, this is just brief telling you, when you want to study and I don't know where to begin, if you're not sure about your seizure medications, I'd brush up here. I've given you the main areas here of the treatment of kind of medications used. I'd brush up here. I'd understand why these medications, which is a very broad area here, but I've given you the main points and how you care. This is where you brush up on this. Okay, so you always want to maintain a baseline of when you come in of how they are. And so you know if there's any subtle changes during your shift. In an ICU setting, they like to be able to give the same nurse if possibly, but that's not always the case. So you need to be assessing after report right away. Are they looking at you? Are they tracking? Is this how they've been for the last 5 days? So you can understand if there is a decline, if there is an improvement, and be able to report that. Okay? Assess patient and family understanding of preparation for surgery. Provide information, reassurance, and support. So allowing them to know, remember, none of this is a cure. All of this is possible treatment, and we have to allow nature and the patient to heal and run its course. So postoperative care is aimed at detecting and reducing edema, right? This is some of our goals here. So making sure that these numbers and values stay the same. Lots and lots of pain here, relieving pain. Again, this patient may not be able to talk with you. I'm trying to always give you this environment, paint the picture of this environment you're going to be in. Okay? So relieving of pain. So it'll be a nonverbal cue, grimacing, tense body, maybe able to nod. Seizures could be huge after a brain surgery. Unnecessarily common, but common. So we want to, as stated in the last slide, to prevent that, maybe with some medications. Sometimes they come out on a drip to prevent it. Monitoring ICP very closely in neurologic status, grips, pushes, pulls, movement, sensation, bowel movement, control of body, control of limbs, everything, urine. Do they know when they have to pee? Do they not? Are they not even able to respond at all? Patient may be intubated and have arterial centrovenous lines as well. They are going to have multiple invasive lines, which would be a central line, which would be an arterial line. Numerous different lines, now plus the intracranial pressure monitoring in their head. Okay, so some other interventions here would be frequent ABG checks. This is why they have this arterial line. Respiratory function, making sure if they are intubated, that they are being supported, that the settings are supporting the patient, that they're correct for the patient. You do not want a lot of PEEP pressure possibly with somebody with intracranial pressure, right? That defeats the purpose. So again, do you see the issue here? If the patient is having a CO2 issue, but we have intracranial pressure, but we can't give too much support with PEEP, What does that mean for the patient? I'm just trying to paint the picture for you of how critical these patients are. Okay. Constant vital sign checks. All right. Assess dressings as ordered and how often, making sure even if it's not ordered to change a dressing, you have looked at it. It is not saturated. There's not copious amounts of blood on it. Okay. Monitor for potentials of seizures. Seizures occur. You have to keep the patient safe. Back to second semester, right? Rolling them on their side. Oxygenate. Monitor for signs and symptoms of complications, fluid status, frequent labs. Here's the most common diagnoses after surgery that you will see. Think about it. They can spend months, years without that piece of skull. They have to wear a helmet. They have to learn to walk again, talk again, depending on the injuries, taking care of themselves, bathing themselves, independently urinate again, independently poop again. So many different things. So I'll let you go through those. When you're reading questions, when you're studying, what is priority for this patient? Here's some of the main priorities right here, but that doesn't mean every patient's going to need cerebral perfusion first. We may be at the point of rehab care where now maybe we're at a depression of what's happened to us, and it's a body image issue. Read the question. Read the case study. Look at your patient. Okay. Some of the most common complications that increase ICP and we can't get it down, that can cause permanent cell death and brain damage, bleeding and hypovolemic shock in the brain, fluid and electrolyte disturbances, infection, CSF leak, seizures. Gone through most of those. Here is our goal in planning for these. Improve tissue perfusion, adequate thermoregulation. Again, you are constantly checking to make sure these patients are okay. Normal ventilation, ability to cope, adapt change of body image, depending on where your patient's at. Okay, so maintaining cerebral perfusion, monitor respiratory status, assess vitals, there it is, every 15 minutes to 1 hour. Strategies to reduce cerebral edema. We're going to have the procedure, we're going to decrease stimuli. We're going to avoid extreme head rotation. This patient should not be moving, should be calm, and have the most perfect, optimal environment. That head of bed should never be, should always stay at this point, maybe flat or elevated 30 degrees according to the needs related to the surgery and the preference and what is going on with the patient. Remember, it changes, but understand why you're doing it so you don't have to memorize everything. All right, so regulating, cover patient appropriately. This is kind of bit repetitive. We're still kind of going over the same things here. The gas exchange. But again, turning position every 2 hours. Remember from respiratory, those optimal positions for perfusion and for respiratory issues. Suctioning to open that airway and keep it open to decrease any kind of aspiration or any kind of issues there. Humidification of oxygen for the patient. Sensory deprivation, enhancing of self-image, same. That strict eyes and nose. That fluid and electrolyte balance, patient education, self-care, assessing for potential CSF leaks. We'll get into that. I think it's the next recording lecture I'm doing right now. Some signs and symptoms. Let's go over that real quick because we haven't, just in case. Clear fluid. If you know this patient's had a brain injury, clear fluid running out of the nose, out of the ears. Certain tests, a halo sign, that we've tested to make sure that it is CSF. Okay, but this is a big one here. All right, this concludes this chapter.